So hello everyone again. We are here for the next part of our OBG Recall with Team Polaris. So hopefully the previous sessions have been of use to you and you've learned new tips and tricks from the classes you've had, and you've been able to go back and revise them from the exam pack as well. So without any further ado, let's go on to our next session. This is very important because this has a lot of important obstetric topics, especially such as labor-related issues, and puerperio. So let's move on. So the first session is going to be on abnormalities in passage. So when I talk about abnormalities in passage, I'm talking about difficulties with labor. So you know that there are 3 P's important with labor. Now also there is another 4th P that's been recently added. It's power, passage, passenger, and now the 4th one is psyche, meaning patient's mental well-being. So the first question that we have. Abnormalities of the passage include which of the following? So if we have students with us, could you please write in the chat box, what do you think are the correct answers from the options given below you? So abnormalities of the passage, right? So the passage is basically the pelvis that we have. Okay, the pelvic bone. So you could have a problem with the inlet, problem with the mid-pelvis, or a problem with the outlet. So abnormalities of the passage would include a contracted pelvis. A contracted pelvis is basically where the pelvis is smaller in more than 2 dimensions or 2 planes. Abnormal pelvic configuration, yes. So again, it could be one of these where the pelvis is specifically contracted in an anterior-posterior transverse diameter. Abnormalities of the vertebral column. Why this is important? Because the amount of your lumbosacral attachment, the amount of lordosis that could be there would affect the baby's ability to enter the inlet. Okay, that is where the asyncretism can happen, right? This is one of the mechanisms where you could have difficulty in baby's descent or engagement occurring. So this is an important factor. Also, if there's an abnormality of the vertebral column, by effect, there will be abnormalities in the other surrounding bones. Similarly, lower limb deformities, because lower limb deformities, such especially with people who have had developmental defects or even acquired problems such as polio, will have a pelvic problem. Okay, any lower limb problem is bound to be associated with the problem of the acetabulum, which is also going to result in a problem of the pelvic bone. So that's also going to be a cause of abnormality of passage. However, a macrosomia by word itself is something to do with the passenger, the baby. So macrosomia is not an abnormality of passage, and this is our odd man out. So that was the first question. The next one is Caldwell-Malloy classification includes. So in our videos, we do have a mnemonic to remember this. So I hope you guys remember that. So if you could answer and tell me, what do you think? Which of these are part of the Caldwell-Malloy classification? So the mnemonic that we had was GAP, like the brand GAP. So you have gynecoid, android, anthropoid, and platypaloid. It transfers oval as such is just a description, right? It's just a shape. It doesn't tell you what is transverse oval. So, you know, if you remember, you have a transverse oval inlet in platypaloid, right? You would even have a transverse oval sometimes with androids and anthropoids. So this technically is not a classification of pelvis, it's just one particular plane that's been described. The actual classification are these named: gynecoid, anthropoid, android, and platypaloid. So cephalopelvic disproportion, right? Okay. Cephalopelvic disproportion is due to which of the following options? Contracted pelvis, a large baby, pelvic dysfunction configuration, fibroid, or fetal malposition. So which 3 of these options do you think would be a cause for cephalopelvic disproportion? So a contracted pelvis, yes. A large size fetus, yes. Fetal malposition, yes. Okay. A malformed pelvis as such would not be a part of cephalopelvic disproportion. You see, in a cephalopelvic disproportion, basically, when the word that you mean is you have a normal pelvis, you have a normal baby, but this baby and pelvis combination just do not work. It doesn't mean that, see, for instance, this baby could be 3.5 kg. With a better pelvis, this baby would be able to be born vaginally uneventfully. But with this particular patient's pelvis, you're having some difficulty. So there's a disproportion between the baby and the pelvis. It doesn't mean that there is a problem in the pelvis as such. Okay. So ideally, we would not consider pelvic dysfunction as this. Neither would fibroid. Now, fibroid is a problem in the uterus. Okay. So there is a uterine mass that is causing obstruction. So it's going to be a reason for blockage in the passage, but it is not a CPD. Because CPD means you have otherwise everything looks okay, but there is a minimal mismatch between the baby and the mother. Similarly, fetal malposition will cause cephalopelvic disproportion because if the patient has a anthropoid pelvis, they would be able to deliver an occipito-posterior baby. But an android pelvis would land up in a deep transverse arrest due to CPD. Remember that. So in android pelvis, there is no the baby gets stuck in the posterior or direct occipito-posterior position. Whereas the anthropoid, there is a mechanism for delivery because the pelvis is anterior-posteriorly longer. So baby will prefer to turn backwards and will remain in that position and will have a face-to-pubis delivery. So the next question. So in a case of CPD, what do you see? Now, like I've already mentioned, in a case of CPD, the baby and the pelvis are not matching. So because of that, you would have problem from the very beginning. You may have problem with engagement, with descent, or at final birth, depending at the level of which the disproportion is quite significant. So let's start from inlet, mid-pelvis, and outlet. So you have the pregnant abdomen, you have the pelvis, right? So now let's go through the options given for us. Would you have a pendulous abdomen? What would be the reason for pendulous abdomen in CPD? When you have difficulty with the inlet, right, the baby's head does not get engaged. So because the head is not getting engaged, the baby still remains predominantly in the maternal tummy. It's not even entered the pelvis, not even fixed. Forget engagement, not even fixed. So because of that, on your clinical examination, you would notice a mobile head. It would be a pendulous abdomen. It could even be a deflexed head. All these three options mean one and the same thing in a different version of it. Malposition, again, why? Because if there is some amount of CPD at the inlet, the baby will try to rotate in the wrong way. So you know that occipito-anterior position, left, is the preferred. However, sometimes if the pelvis is abnormally shaped, the baby may go for a occipito-posterior position. So with an occipito-posterior position, you notice that the pelvis would have this weird flattening, subumbilical flattening, because the baby's back is going to be behind, right? So when you notice this abnormal subumbilical flattening of the below the subumbilicus, the tummy is flattened out, that is, you have to be suspicious of occipito-posterior presentation. Similarly, malpresentations. If the head can't go down, the baby is free to keep moving. And that could result in breech, transverse lie, etc., or even oblique lie. Now, previous CS not necessarily means that you would find it in a person with CPD. Now, because see, you are examining a case for CPD for the first time. So it's generally a primiparous person, right? Because if she was multiparous, right, in a multiparous patient, that means she's either delivered previously and this particular pregnancy has resulted in CPD, right? So you would not really necessarily to see a scar. However, if a person has had a previous scar, you would not be examining them for CPD the next time around because you already know the first cesarean was done for a particular indication. So this, although you could justify by debating that why you would see it, is not a very straight-cut answer. Okay, we're looking for very obvious answers here. So from this, all of this is what you would typically see in a case of cephalopelvic disproportion. So your answers are A, B, C, D, and E. So trial of labor. So what is trial of labor? Trial of labor is when you have mild degree of CPD, where you're assuming, what do we mean by this? Where we assume that the difference in the pelvis is less than 1 centimeter from the major diameters, and we're assuming that molding will help compensate. Molding, the maternal urge to push the contraction of the uterus will help get over this obstruction. Now, where are you not allowed to do a trial of labor, right? Trial of labor should not be done in someone who's got a mid-pelvic or outlet contraction, because even though the head may get engaged and you have a very severe mid-pelvic contraction, that means you're going to face a problem at the time of fetal descent. Very rarely do you get isolated outlet contractions, okay? If there is an outlet contraction, there is going to be something in the rest of the pelvis. So very rarely you get this isolated, but if you have a mid-pelvic contraction which is significant and is more than mild, then there's no point of giving trial of labor because you know that the baby is going to get stuck. Severe contractions. That means severe contractions is directly a no-no because the definition of trial of labor means it is for mild degree. So it is not supposed to be done in severe contractions, not supposed to be done when you're having already a mid-pelvic significant contraction. Lack of lower segment cesarean section availabilities or intensive care because it's a trial, right? So when you're doing a trial of labor, you are assuming that there is a probability that you may fail. And if you fail, you have to do a CS. If you don't have the ability to do a CS, then you should not be having this patient within your facility. You should refer them to the necessary higher center where they can be properly cared for. Now, preterm labor is not a contraindication. If a person comes to you in preterm labor, obviously you're more concerned about the need for NICU facilities, but it doesn't mean that you can't give them trial of normal delivery because you may assume that generally preterm births are quite fast. They are faster than a singleton term baby's birth. However, your only concerns are one, you need to have an NICU. One is protecting the preterm head because they are very fragile and chances of intracranial hemorrhage, bleeding within the brain are quite high. So you have to be very, very careful for this. Other than that, it is not a contraindication for trial of labor. And the term trial of labor would not even be applied for preterm because the definition again is term. So this is an incorrect option. So your answers are trial of labor is contraindicated when you have significant mid-pelvic outlet, severe contractions, or lack of necessary facilities to treat the trial of labor. Okay, so we finished our first set of questions. So now we move on to the normal puerperium. So normal puerperium, what is the meaning of normal puerperium? So if students could just answer this question for me. Normal puerperium is a period from delivery of the placenta till 6 weeks. These are physiological changes during pregnancy that revert to normal in the postpartum state, associated with pervaginal blood spotting. Period from the delivery of the placenta till 2 weeks. So which of these options do you think are correct? So more than one option can be right, correct? Okay. So the normal puerperium from this is A and B. Okay, these two options are correct. It is not always associated with bleeding. Okay, that's a very vague answer, so that's not correct. And it's not till 2 weeks. It's actually till 6 weeks. So this is wrong. So these are your wrong options. First, A and B are the correct options. Any doubts regarding this? So the second question is, anatomical and physiological changes in normal puerperium are, which of the following are correct? Uterine involution, contraction thickening of cervix, endometrial regeneration, or persistent vaginal bleeding. So as we've already answered through our previous question, this question is also got the similar option. So we know that this is wrong. Persistent vaginal bleeding is not a part of normal puerperium, right? So we know that normal puerperium, there's involution, there is regression of changes in the cervix and the endometrium, regression of the breast, changes in your skin, limbs, joints, etc. So this is not a part of it. Okay. Uterine involution occurs as per. So you all are aware that uterine involution takes 6 weeks and it occurs at stages. So let's draw this. Immediately after birth, this is the pelvis, this is the umbilicus. Immediately after the birth of the baby and removal of the placenta, it lies at the level of the umbilicus, correct? Right. So what we have a dictum is that the uterus is supposed to go down 1 centimeter per day. So at the end of 1 week, it is midway. Okay, that's 7 centimeters between the umbilicus and the pubic symphysis, between both of them. By the time of 2 weeks, you should not be able to palpate it anymore. Okay. And then it will still, now even at the time of 2 weeks, that means it's still the size of approximately 10 to 12 week pregnancy, because you can't palpate beyond that. After this, it will still continue to regress for the remaining 4 more weeks. So from your options, can you tell me which of the following are correct? After third stage, the level of the umbilicus, is that correct? Yes. After 1 week, it's midway? Yes. After 2 weeks, it's the pre-pregnant size. No, we just discussed that. That's going to be at the end of 6 weeks. At 6 weeks, after 6 weeks within the pelvis, wrong. It's at 2 weeks. Remember this, okay? To no longer be able to palpate a postpartum uterus, the cutoff is 2 weeks. So if any woman comes to you in the clinic complaining of persistent postpartum spotting, bleeding, tenderness, pain, etc., and you are still finding her uterus even after 2 weeks, you really need to look for puerperal endometritis, right? Or rural puerperal sepsis. Very important differential. Okay? Only by 6 weeks is the uterus normal, but by 2 weeks it is no longer palpable per abdomen. All of the following are correct in terms for lochia. So even for this, we have a mnemonic in our class. So it's RSA. Okay. Rubra serosa alba. So first 4 to 5 days, lochia rubra, yes. Next 2 to 3 weeks, serosa, yes. From 6 to 8 weeks, alba, correct. This 4 to 8 weeks lochia is obviously not right because we know that lochia can be there up to 42 days or 6 weeks. So this is the wrong option. This is not the correct answer. General advice to a patient in the puerperal period. So this is something I want you guys to really read because one, this question answers everything that you have to remember about postpartum care. Secondly, this is something very important because after birth, the women tend to get neglected and postpartum care is just as important, right? So this is a list of everything that you have to tell the patient in one setting. Ambulation, care of bowel and bladder, care of the perineum, diet, supplements, breastfeeding and care of the breast, immunization, neonatal care. ARM is obviously got nothing to do with puerperal. This is artificial rupture of membranes, which is something to do with labor and has no role here. So all of this is the general advice. If any specific complications occurred, like there was an operative delivery, a baby requiring ICU care, etc. So, or she has any medical disorders. So you would specifically give them some specific treatment in addition to all of these things. But this is the basic stuff that you have to remember for every puerperal patient. Okay. Next, another important labor topic, which is operative vaginal delivery. Now, with operative vaginal delivery, you need to remember that what kind of instruments do you have? You have forceps, vacuum. Okay, vacuum, you also have your metal cups, the celastic cups, the kiwi, right? With each one having their own pros and cons. Forceps, you have basically now only outlet forceps are considered. There are no more role of mid-pelvic forceps, rotational forceps technically in modern day obstetrics because the thing with rotational forceps is the trauma to the mother and baby outweighs the benefit of having a cesarean, and the training and the expertise for such instruments no longer exists in modern day practice. So, but everything will be taken as a per patient basis discussion. Okay, it's not like you can label and say that no, it's never ever going to be used. But if you have the expertise on hand or you've been able to see it, then yes, it can be considered. So these are the two forms of operative vaginal delivery. What are the indications for operative vaginal delivery? So you have maternal indications and fetal indications. So why I'm telling you to answer questions like this is rather than read the answers and then think, okay, whether this was there or not, think for yourself, because that way, when you see your option in the answers, it will reiterate or it will boost your confidence so that you can maintain your, your energy, your enthusiasm throughout the exam. Whereas when you have to play a guessing game, then the probability of getting the right answer would also start to go down. So try to think, whenever it comes to obstetrics, especially with complications, medical disorders, always think maternal, fetal, finished. If you say maternal, fetal, you're most likely going to answer everything in that. So see, prolonged second stage, maternal complication. Exhaustion, maternal complication. Cardiac disease, yes, because you want to cut short the second stage of labor because with each contraction of the uterus, it increases the cardiac output by at least 15 to 50%. Right? And that's going to increase the possibility of pulmonary edema, which is why we want to cut short the second stage of labor. Gestational diabetes, not an indication. Autonomic dysreflexia, yes, it is an indication. Now, this is not something you may commonly encounter in routine practice, but it is. Why? Because people who have spinal cord lesions will have autonomic dysreflexia because they do not have control of the stimulation to the autonomic nerves. So the pain stimulus, they may not feel pain. Okay? They may not realize they're having even labor pain for that matter. But because of the stimulation to the nerves, it will result in autonomic dysreflexia, which can cause severe hypertension, can even cause cardiac arrest. So it is something that requires that at full dilatation, you should cut short the second stage of labor and have an ICU team ready. Malpresentations, malpositions. This is a fetal indication, right? Very good. If you wanted to add more points, you could even see fetal distress after coming head of breach, which is again a part of the malpresentation. Okay, so these are points for maternal fetal. Finished. So from this, you can see that gestational diabetes is not an indication for working. Obviously, if you are having some form of CPD or you're suspecting fetal distress because of CPD, and then you're putting an instrument, assuming that you verified the instrument works, you could say that would be the indication. But just because the patient is diabetic doesn't mean she needs an operative vaginal delivery. So see the wording when you're answering the question. So what are the parts of a forceps? This is very important. Okay, so you have the handle, you have the shank, you have the lock, you have the blade, and you have the finger guard. Yeah, it's a very rough drawing. Base is not really a part. Okay, you have the cephalic curve, the curve that goes for the baby's head, right? And you have the pelvic curve. Those are the additional 2 points to remember. So everything else is a part of the forceps, not base. So they can trick you by using such terminology. So when you draw it yourself, you know that yes, this does not exist in the label. Advantages of vacuum over forceps. Okay, so vacuum over forceps. Okay, let's see what's the advantage. Regional anesthesia is not required. Why do you think vacuum would not require regional anesthesia, or at least not as much with regards to forceps? So if you've seen the instruments yourself, you would notice that vacuum is just a cup. By innate nature, it's just not as bulky. But when you see the forceps, you have to insert an entire spoon, almost like the shape of a hand, into the vagina. Because of the size of it, and because of the patient's apprehension that they're going to definitely need regional anesthesia. It does not mean you would not give it to a vacuum person, but you can make do with just your local perineal analgesia. That's it. You don't have to go pudendal block. Whereas for rotational forceps, especially before it was done, pudendal blocks were routinely given. So regional anesthesia is actually not required and not essential. Okay, less space occupying. This answers the first question itself. Because it is less space occupying, you can easily apply it. Even if you're having a very tight vagina or you're having very stuck head and you're not able to get much place to manipulate around it, you can use a vacuum much more easier than you could have used a forceps. Less compression force. So yeah, now this you can have 2 ways of thinking about it. Now with the forceps, this is the fetus. The forceps will be applied like this around the fetus, right? So if improper application can cause damages to the face of the baby, nerve injuries, right? But the plus point is the head injuries are less with the forceps because there is no traction. The traction is across the bone. Whereas with the vacuum, the traction is mainly along the baby's head. So you may have less face injuries, but there's an increased chance of cephalohematoma. So it's less compression force, obviously. There's no compression happening with a vacuum. Vacuum is just a pull. Easy to achieve rotation. Now, this is wrong. Now, the problem is vacuum is that, again, you're gaining ease of application, less maternal trauma, less fetal trauma probably, and less time to put it in and less anesthesia. But what you're losing is you don't have that much force. With forceps, the force that you gain to apply an instrument and to pull the baby is much more than you have with a vacuum. So that is where we have a loss at. Less genital tract lacerations, yes, correct. So similarly, if you want to make a question for forceps, now with forceps, let's try to clear all of this and see what happens. Okay, if you wanted to say what would be the advantages of forceps, here you would have to give regional anesthesia. It is definitely space occupying, right? It will cause less compression force, but it will cause less chance of cephalohematoma, easy to achieve rotation. It will definitely have more genital tract lacerations. Okay, preferred in preterms, right? Preferred actually even in individuals with cardiac and pulmonary diseases. Why? Because the reason why forceps will be preferred here is in women who have a cardiac lesion, you don't want them to push as much. But you're more scared that if a cardiac patient has a very traumatic vaginal injury, that they would bleed out even more. So you have to weigh the balance. So because individuals are more well trained with vacuum, nowadays vacuum is the norm, but even forceps still has its presence with trained obstetricians. Advantage being you can get rotation. So in occipito-posterior, forceps is preferred. After coming head of breech, forceps is preferred. Remember, forceps is the only thing you can apply in an after coming head of breech. You cannot use a vacuum. So that is also another question to understand. So the last question that we have, aftercare following assisted breech. So once you have done the procedure, what is your postpartum care? Antibiotics, hygiene, analgesia, physiotherapy, counseling. This is very, very important because women can experience post-traumatic stress disorder after any difficult birth. Doesn't just mean operative birth, any difficult birth, any bad obstetric outcome, even any complications to the mother like PPH can also cause PTSD. So you should counsel the patients. No role of steroid administration. Okay, this has nothing to do with assisted vaginal birth. This is whether it is forceps or vacuum. Again, institutional protocols may vary with regards to antibiotics, but it's usually routinely given because most of these women will have an episiotomy. And because of the episiotomy offered and the conditions under which the instrument was applied, you would want to give them antibiotics. Preterm labor and birth. Very interesting topic. Lots of new recommendations have come in place. So what is the definition of preterm labor? Okay, so here, prematurity So prematurity basically can be pre-viable and viable. Okay, that's what the trick in this question was. So whether it is 20 to 20, 37, 34 to 39, 37 to 41, or more than 41 weeks. So let's answer what each one of these means. More than 41 weeks is your post-term, right? 37 to 41 weeks is your term baby. 34 to 39. This would not really be falling into any categories. 20 to 37 is preterm. Now, in the 20 to 37, if you wanted to have a better answer, you would say 20 to 28 is pre-viable prematurity, and 28 to 37 is viable preterm babies, because these are the category of preterm births that we can intervene with our medications to help improve neonatal survival. In this category, there is not enough evidence of any medication to work that will help. So our main concern is on this group. Okay, what are the risk factors for preterm birth? This is also an important question, because only if you know what are the risk factors for preterm birth will you be able to pick those women up in your OPD and counsel them or give them the necessary intervention, right? So if you guys could answer in your chat box and tell me what are the risk factors according to you for preterm birth. So is previous preterm birth sound like a risk factor? Yes. Short cervix? Yes. Congenital anomalies of the fetus is not a risk factor. Okay. Bleeding and infection? Yes. Artificial reproductive technique? Yes. And previous VBAC? Not a risk factor. Okay. So these are not risk factors for preterm birth. The rest of them, yes. All right. Now, in why previous preterm birth is a risk factor? Because already there's an existing pathology. Short cervix, because short cervix could be the cause of secondary miscarriage, could have been the cause of previous preterm births, right? So remember this, because these are the women who, if you find in your OPD, you have the role of giving them progestogens, advising them to avoid heavy lifting, and keeping them under close contact. If they've had recurrent second trimester miscarriages, the role of cervical sutures can also be discussed. So maternal medical disorders that can cause preterm birth. So maternal medical disorders that can cause preterm birth. So let's go up through these options. Basically, you can have an iatrogenic preterm birth, okay, or because of the pathology the mother has. Iatrogenic preterm birth means we have caused a preterm delivery because of some complication. So generally, women with hypertensive disorders, Apla syndrome, growth restriction, etc., you would cause an iatrogenic preterm birth because most of them are going to have growth restriction. Okay, hypertension, APLA are going to have growth restriction, which is the reason why we try to control them, or we control their blood pressure, we give them ecosprin, we even give low molecular weight heparin for women with APLA, right? Diabetes can cause iatrogenic prematurity if it is extremely uncontrolled, like severe diabetes requiring high amounts of insulin, even at the gestation age of 36 weeks, even 35 weeks, if you're thinking the sugars are not at all going to get controlled, is an indication. And this is actually an ACOG recommendation. Sheehan syndrome is not. Why? What is Sheehan syndrome? We've already discussed this in our previous recall. It's basically a complication of postpartum hemorrhage. So by effect, not a cause of preterm birth. Antepartum hemorrhage, yes, because antepartum hemorrhage will cause recurrent bleeding within the placenta, will trigger the uterus to contract and cause preterm labor. Multiple pregnancy, yes, multiple pregnancy will also cause preterm labor, because by nature itself, twins are associated with a higher risk of preterm birth because of over distension of the uterus. So yes, those are our options. Treatment modalities for preterm birth, very important. Okay, what do you think would be the options here? Corticosteroids, tocolytics, magnesium sulfate, or methotrexate? So the more than one answer is right. The options, correct answers are A, B, and C. Okay, D obviously is wrong, right? Now A, what is the role of corticosteroids to help with lung maturity? Tocolytics is to help give you time for the corticosteroids to act. Magnesium sulfate is for neuroprotection. Magnesium sulfate mainly has a role of greater than 30 weeks. Okay. Lung maturity, you can give it to anybody who's greater than 28 weeks. The maximum benefit is between 34 to 37 weeks. So remember these points. What are the corticosteroids you can give? You can give betamethasone, or you can give dexamethasone. So we have a mnemonic given in the class for this. B is the second alphabet. D is the fourth alphabet, right? Why am I saying alphabet numbers? So how I used to remember is that there are 2 doses for betamethasone. So 12 milligram, 2 doses, which are 24 hours apart. You need to remember. Whereas with dexamethasone, they are 4 doses. So 6 milligrams. Oh, so also equals to 24. So, but basically, these are given twice a day. Dexamethasone is given twice a day, 6 milligrams over 2 days. Betamethasone is given 1 dose per day. So this is how I used to remember my dosing. The total would always be 24. So remember that. Neonatal complications. So our main concern with preventing premature birth is because we're scared of what could happen to the baby. So could you please answer and tell me, what do you think are the neonatal complications of prematurity? Is it Down syndrome, hypothermia, respiratory abnormalities, cardiovascular abnormalities, intracranial hemorrhage, or neurodevelopmental disabilities? So obviously, the outlier is Down syndrome is not an answer. Hypothermia, yes, because preterm babies are unable to maintain their homeostasis as well as term babies. Respiratory abnormalities, yes, because RDS is a big problem, which is why we give our corticosteroids and sometimes even surfactant. Cardiovascular abnormalities, yes, because the PDA closure may not occur. Intracranial hemorrhage, yes, because of trauma to the preterm head. Neurodevelopmental problems, yes, because they're very periventricular leukomalacia, periventricular hemorrhaging is very common with preterm babies because of the nature of the matrix in the brain structure, which is why we're also worried about these bleeding that can happen in internal brain. This can even lead to future cerebral palsy. So these are complications associated with neonatal birth, preterm birth. Okay, Downs is nothing to do with premature babies. Okay, Downs, having a fetus with Down syndrome does not mean it has an increased risk of preterm birth. So now we come to the last leg of our recalls. Stages of labor, very important again. Okay, what are the events in the first stage of labor? So first stage of labor, let's go through each of the options. Regular, painful, progressive. Yes, that's when you know the patient is in true labor and not false labor. There is show. Yes, show is basically the mucus plug that is lost when cervical effacement and dilatation happens. What is effacement? Effacement is when the long uneffaced cervix becomes short and becomes papery thin. Okay, this is effacement. Dilatation is when the cervix starts to open. So you have a cervix which is 1 centimeter dilated, like 5 centimeter dilated, and fully dilated. There's nothing there between. Formation of the upper uterine segment. Have you ever heard of something like that? There is thickening of the upper uterine segment because of retraction of fibers from the lower uterine segment. Okay. Descent of the presenting part. Yes, that is a part of first stage of labor as well. And formation of the bag of membranes. Descent is there throughout, even first stage and even second stage, right? But it's an important part of labor in general. Formation of upper uterine segment does not exist. Okay, that's not a part. Okay, what is the Bishop score? Very important. You have, it's a cervical score. Yes, there's dilatation, length, consistency, position, head station. This is not there. Okay, you don't require NST for that. However, if you remember in your biophysical profile, that is your Manning's biophysical profile, sometimes the NST is a part depending on which biophysical profile you're actually looking at. But it is not a part of Bishop's score. So don't get confused in the stress of your exams. So like I said, cervical, this is the cervix. You have an uneffaced cervix to a well-effaced cervix. Okay, it's become short. So you have a closed cervix to a dilated cervix, right? The texture of the cervix, whether it's firm, whether it's hard, firm, or soft, like the lips, right? The position of the cervix. That means if this is the vagina, the cervix could be here, here, or here. So when you put your fingers inside, what you first should feel is the middle position. If you have to bend your fingers anteriorly, it's the anterior position. Or you have to go posteriorly, it's a posterior position. So anterior, mid, post, posterior. Where is the fetal head with relevance to the ischial spines? So head could be here, could be -3, -2, 1, 0, 1, 2, 3, right? You're assuming where the vertex is. Then station of the head, even the position of the head. Where are you feeling the fontanelles? Either you're feeling the posterior fontanelle anteriorly, which is the normal position. You should never actually feel the anterior fontanelle. If you feel the anterior fontanelle, means what? What do you call that condition? So what I mean by this is, look at the fetal head, all right? In a well-flexed head, you would only feel the posterior fontanelle. Anterior fontanelle is out of reach. This is the well-flexed head. Whereas if the head is deflexed, you would feel both the posterior and anterior fontanelle. That means a bigger diameter of the head is the presentation right now. So this generally happens in your occipito-posterior or deflexed heads. So you should never really feel this. And this is very important to see the position, both of the cervix as well as the baby. Okay. But again, fetal head position is not part of the Bishop score. Only cervical position is part of the Bishop score. Okay, what is part of the active phase? Now, active phase, can you tell me which of the following is correct? It begins at 2 centimeters, ends with full dilatation. It has an accelerated phase, a maximum slope, and a decelerative phase. So yeah, this definition has now been changed. Initially, it was 3 centimeters, and it has now been moved on to 4 centimeters. So this has changed. It is no longer begins at 2 centimeters. Ends with full dilatation, yes, right? At 10 centimeters, the next is your second stage of labor, which is the fetal descent. It has an accelerated phase of maximum slope, and has a deceleration phase. Okay, so generally around 6 to 8 centimeters, you have a deceleration phase where the dilatation happens relatively slowly. On average, you should have 1 centimeter per hour dilatation. Second stage. So what are parts of the second stage? There is a pelvic phase. Is that correct? Yes. There is a perineal phase. That is the phase of expulsion. Do we have uterine contractions in the second stage of labor? Yes, the expulsive force is there. Do you have any cervical effacement in the second stage? Now, what was the definition of second stage? After 10 centimeters. That means there's no longer a cervix. Cervix is well effaced and fully dilated. So there's no need for effacement in second stage of labor, right? So this does not exist. Are there bearing down pains? Yes. Is there crowning? Yes. Will there be an expulsion of fetus? Yes. All of these are the points that happen in order of sequence for birth to occur in the second stage of labor. Okay, so our last question, placental separation. So we finished the first stage, we finished the second stage, and now we're in the third stage. Very important part. So placental separation, second to third stage, basically, we're transitioning. So here you have which of the following are parts of placental expulsion. You have a latent phase, contraction phase, detachment phase, expulsion phase, and something called lengthening. Now, this is not correct. Okay, there's no such thing as a lengthening. These are all correct. You have a latent phase where what happens is the placenta will start to separate on its own because of uterine contraction. Then with proper uterine contraction start setting in, the placental site will start to shrink, but the placenta is still a bulky mass. That means placenta was sitting like this, but now the uterus has shrunk. So there is going to be a shearing of the placental mass off of that. So this will lead to detachment. So the placenta is going to detach from the uterine wall. And lastly, the placenta is going to be a freely standing structure within the uterus, which is going to be pushed out, called the expulsion phase. So now I have a question for you. Do you remember the two mechanisms of placental expulsion? You have Duncan's and you have Schultz. You remember what they mean or how they present? This could also be a question in MCQs as well. So you have something called a dirty Duncan or a shiny Schultz. So what that means is, it depends on the surface that you see. If you see the fetal surface, which just got membranes, right? That's going to be your shiny Schultz. Whereas if you see the maternal surface, where you've got these cotyledons, etc. present, right? That is going to be dirty Duncan. So that's an extra point to remember. So we are now at the end of our session. I hope it was as informative to you as it was fun teaching you guys. If you have any doubts, do feel free to get in touch with all of us. And I wish you all the best for your exams. Do look into the exam pack so that it can help you revise through your points for discussions. You can clarify all the doubts that you have by seeing the videos and by seeing the mnemonics, the way of learning that we have come through. Thank you for listening, and I wish you all the best.